Hello and welcome to EMS Research with Professor Bram, where we talk about research-related issues that matter to those who work in emergency medical services. Today, we'll be talking about hypoglycemia. Welcome to EMS Research vlog and podcast from the studio here in Houston, Texas. I'm your host, Bram Duffy. I'm a research fellow with the Institute for Social Innovation at Fielding Graduate University. I also have an appointment as an assistant professor of communication at Kennesaw State University. I'm actually doing a research study right now that's open for first responders. And so if you don't mind being interviewed by me, I want to encourage you to go by my website and fill out the form. I'll talk about it near the end of the show, but the website is professorbram.com. So it's professorbram.com. The other thing is, before we get started, I want to mention that I've written 2 books on communication, and the most recent book has been just recently released called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. So you can find a link below, or for sure hang out at the end and I'll tell you more about the book. Today, I am really excited because I'm here to introduce a guest. His name is Eric Chase, and there's a lot of cool stuff to tell you about him. So please welcome Eric. He's a seasoned paramedic with sort of a humorous twist because since 2005, he's been part of the EMS community doing all of these roles, from paramedic, fire paramedic, flight paramedic, field training officer, clinical services manager. And he's also been in law enforcement from 91 to 2003. So a long career there. All that stuff has really equipped him with a unique blend of experience. And so today he takes these rich experiences into classrooms and training stuff for various first responders. And he also has a background as a comedian. So he does do some comedy add-ins to his training. And so I am just really excited to be here with Eric today. So Eric, is there anything I missed about that folks need to know about you?
First of all, thank you very much. It always seems very more illustrious to hear someone read that when we're talking about lowly old me over here and the experiences that I've had the opportunity to have. What I find is interesting is that kind of comedian that you talked about and using improv. I am not very funny, but we do utilize that role of play in order to get the people the right brain, left brain integration for people to start to see and feel. And when we're using the full body to connect and engage with one another and utilizing our mirror neurons to incorporate that engagement, learning can really happen. So we can really drive that knowledge and skill gap and narrow it when we're using improvisational techniques in the applied improvisation. The one other really cool thing, and I know my wife's happy about this, is that the last 3 or 4 years I've been studying pre-med courses, physiology, chemistry, biochem, organic chem, so on and so forth, because I'm matriculating to RN, and I'm also currently finishing microbiology this semester and started my nursing program this semester. So I'll have an Associates of Art and Science by December of next year. So I like to stay busy, if you will, and I'm kind of forging my path ahead and going to maintain my paramedic license as well.
Well, good for you because, yeah, we need everybody to keep continuing and growing and to know about your illustrious career already, and then to add on, you're going to do more school. That's pretty amazing. You know, the field of EMS, we find things that aren't funny sometimes, right? That's kind of what we do. And it's also a role that we play when we're trying to deal with emotional things that are just difficult to deal with, that we find ways to incorporate laughter. My favorite show is The Fabulous Miss Maisel. I don't know if you've seen that, but it has to do with a female comedian from the 50s. And so I had all these thoughts about meeting you from watching this TV show about a comedian, but now some of them are taken away. Can I ask you, just because I don't know, remind me and the audience also, what part of the country are you in? Where are you at?
So I am currently in Oklahoma City, in the Oklahoma City metro area, and have been here since 2008 and have worked for several large EMS organizations within the state, both Oklahoma City proper and the metro area. So I've had a a great experience learning and growing in the community here since I moved here from Colorado, which is where I started my EMS and fire-based career.
Yeah, you're like the trifecta, right? Like the EMS, fire, you get it all. Let's talk about this article. The article that I found for us to talk about today was initially printed by the National Association of EMS Physicians, and then it was reprinted in EMS 1 in September of 2023, so just really recently. And the title of the article is it safe to treat and release patients with hypoglycemia? Assessing pre-hospital management and outcomes in patients assessed for hypoglycemia. I want to share you more about the article in sort of a summary format. Diabetes is a prevalent chronic condition, and this is something that affects 11% of the U.S. population. So 11% is a big O number. And these hypoglycemia events are common occurrences, especially for people that are on medicine. So these diabetic related emergencies account for 2.5% or so of all the EMS activations out there. And there's this standard guideline. It's the National Model EMS Clinical Guideline that is put out there that helps set parameters so that providers can have an understanding for the level of severity that this patient is under. So these guidelines recommend transport to a facility if the low blood sugar continues or if the patient has had a seizure. But in those cases that are less severe, they are recommending the sort of a treat and release scenario. EMS protocols, though, in general for the treatment of hypoglycemia are really different from place to place. And only 49% have specific policies that regard non-transport of treated patients. And so a study was conducted in Canada, in Ontario, that was aimed to look at some of the predictors of repeat access to EMS or the emergency room within 72 hours of that contact that the paramedic had. And what they did was they went through and did a retrospective review. So they went through old EMS reports and ER records for a full year. And they really kind of focused on people who had blood sugars that were under 72. And what they looked at was that patients on insulin were less likely to need repeat care regardless of the transport. And these findings were suggesting that the whole treat and release strategies that may be safe for certain patients. And as a result of that, EMS leaders might want to consider writing in these strategies so that we can manage these patients differently. I want to say that I've worked in lots of EMS systems that did not have a specific protocol for treat and release. And so what happened was that these patients would get the D50, wake up, sign a refusal, and then I take the IV out of their arm and they leave, and leave. And I have always had mixed feelings about those situations because, this is a patient that was under my care. Nobody else saw them but me. And, what happens, when I'm not there. So this article is kind of interesting because it brings up all these different scenarios that can happen and also highlights the fact that we don't have a standard practice. So Eric, tell me about your experience with diabetic patients. What do you think about this article?
As a student and one that likes reviewing research, regardless of how many times I've run a call, I find that reading that article and then comparing it to other analysis lends itself to me to have more questions when I've dealt with patients. So I retrospectively went back and reflected on a lot of different levels of hypoglycemic patients that I've seen over 15 years and probably should have transported more than I did based upon some of the factors that I think we're going to get into in a few minutes. What I mean to say by that is paramedics do a very good job in EMS understanding those neurogenic symptoms of hypoglycemia, the anxiety, the hyperarousal, the sweating, the palpitations, the paresthesia, the numbness and tingling, which we may even call behavioral changes, but then that kind of reflects itself into a patient that's having the neuroglycopenic symptoms where seizure and coma and all those other more significant issues are coming into play. And what were we witnessing upon our arrival and what was being told to us by witnesses or bystanders, and making a cogent link between what the presentation was and what our treatment modality should be, and should it also include transport. I said a lot of things to say this. I think in EMS, we've done a great job of getting the basic understanding of what And we often are inhibited by a patient immediately saying, I'm good, this has happened to me before, without us maybe knowing and having a little bit more evidence-based medicine and actively engaged medical directors and clinical teams to say that these are some of those factors for which we want you to really try to implore transport versus treat and release at home. I've had patients ranging from profoundly obtunded to snoring respirations to postictal, which is presumptive of seizures. Those patients all I have tried or enticed to go to the hospital. I never go on a call presuming that I'm going to get a refusal. And I think that's another gap where we and myself have jumped over the hurdles to determine whether or not that patient, their best place of action or course for us to do is get them to the hospital so they could be further evaluated. And a lot of times, unfortunately, since endocrinology isn't there and it's just a hospitalist, they kind of get passed along and maybe monitored and evaluated. But we'll get to a few things specifically, and I know I said a lot, so I'll kind of get it back to you.
Well, yeah, the way that I've worked as a paramedic in my training is I think I've learned some of the best lessons from watching other people make mistakes. And so a lot of my pet peeves as a paramedic are really related to that. And this is an off topic, but I'll just tell you that I'm one of those seatbelt people. Like if I see another crew that's pushing a patient into the hospital with no seatbelts on, it makes me nauseous. I'm like, what in the world are these people? It's a major problem, a pet peeve of mine. It's because I've seen people die. I've seen really serious things happen when you don't follow the rules. And as far as I'm concerned, being a good paramedic means that you're a good rule follower because the rules are there for a reason. And this is clinical stuff now. All that to say, when it comes to battling this out with patients and being concerned about people and taking on that liability, what I've done is I have had cases where, don't tell anybody, okay? I've had patients that I put on the ambulance stretcher and I put in the back of the ambulance and I made sure the driver was turning the wheels of the ambulance before I pushed the D50. And the situation was one of those situations where I thought that based on the way the family was talking that this is definitely going to be a patient that tries to refuse. And clinically, he looked horrible. So, yeah, I might be able to get his sugar back temporarily, but this is not a good case. And if memory serves me right, I'm thinking about patients that look like they've had seizures or, been into the low state for a long period of time. This is like an ethical thing, right? So should I have waited that extra 5 minutes to administer that D50 while their brain was suffering from it, or should I have just done it right away? I guess this all comes down to it being situational. And what you and I know is that you put one paramedic in this situation and you're going to get a refusal, and you put another paramedic in the situation and you're going to get a transport. And so without there being protocols that are really specific about this can come up to provider judgment. And anytime it's provider judgment, we can have laziness that plays into the mix.
I want to echo on that and go back to patients that we've seen and to your example that as paramedics, we should be very good rule followers. And I want to echo that. I didn't think about it from that perspective, and hearing that, it afforded me the opportunity to say, I can make very good clinical observations and judgments, and I know to the level and degree for which I study. And yet to normalize those accountability opportunities and conversations by having the rigidity of the protocols and yet being able to have conversations with physicians when we have questions to deviate from those protocols. So when we have that patient that is profoundly low, that really, really clinically looks unwell, my thought is that they should always be going to the hospital. Is it something that they're not doing? Is it something physiologically? Is there a combination of the above? Is it an education that needs to be done? Our first and foremost priority should be optimal care and treat and transport. I know that we're looking at opportunities for treat and release and treat and payment models. And yet we have to be driven in that one direction or not. We're trying to do everything all at once as opposed to still staying defined in the role of what we do, and that is treat and transport. I'm all for all the changes that we're seeing in enhanced education models for paramedics, which is being shot down by the other organizations. All that to be said, when we're dealing with a hypoglycemic patient that looks so unwell and we give them that D10 or that D50, we're artificially elevating their numbers. And we do not know from an epidemiological standpoint or a standpoint of endocrinology what the reason for their crisis was. And oftentimes there are other illnesses and comorbid factors that are playing into the factors. And without labs and without urinalysis and without kidney function checks and assessments, which obviously we as paramedics can't do, I think we're doing a disservice to our patients. You know, if we look specifically up in the studying that I've been doing, if metformin, which is typically given for type 2 diabetics, if that, which we know inhibits hepatic gluconeogenesis, where when there's a physiological response and our body needs energy, our hepatic cells start creating the glucose to be released into the bloodstream. With that being said, if we then have a patient that's been hypoglycemic and they're on metformin, if we give them medication, D10, D50, at what level and how much response will it have to combat or compete against the receptors that the metformin is inhibiting? So are we just quickly getting them to be cogent enough to sign a refusal to then 30, 40 minutes, an hour, 4 or 5 hours later, whatever the time frame may be, to potentially have a greater catastrophic drop over a longer period of time, or the loved one that was there with them did not stay with them because they were fine, and then this person is obtunded, comatose, seizure, and potentially deceased. And these are the factors that I think if we look at evidence-based medicine in these studies, even if it's 1% of patients have issues that are insulin-dependent diabetic patients with hypoglycemia, the metformin, I think, is a greater consideration for us, absent even the comorbid factors with chest pain, heart disease, hyperlipidemia, COPD, CHF, and all these other things that we know the symptoms can mask and mirror.
Yeah, because the liver can only do so much, right? The liver is just, another example is that if you're a diabetic and you drink alcohol, then your liver can't do anything except process that alcohol. So forget your blood sugar, monitoring. And so it's one of the concerns that, we have with diabetics drinking, because like, even though you're taking your medicine, this is sort of totally thrown off the mix. Have you got to take ANP2 yet in your studies?
Yes. I took
those.
Oh
my gosh.
I finished physiology last fall, and anatomy I took 2.5 years ago.
So that's how you really learn about how all this is just totally wrecking the system, and how there's such a small amount of action that can cause the liver not to be able to function like it needs to. And, the thought I have about getting the patient to the hospital are two things. One is that I offload this responsibility that could come back on me as a provider, right? Because I made the wrong choice of getting them there. And the other thing is that my understanding is that most hospitals have a system. So even if you leave the hospital with a diabetic discharge, you get a follow-up call from a certified diabetic educator. So you have something that would be there. Or also, a lot of times the hospital notes will update the physician's notes, right? So if you have an endocrinologist or you have a personal doctor, that doctor's now going to find out that you're bad and you got to go to the ER. So there are those benefits, and that's why this is sort of a tricky thing, because it's situational. And as the provider, we are out there making a decision about, are we going to leave this person or take them? And some paramedics may not have the full training that would allow them to look at all the signs that would prevent this. And then also the part that you mentioned, gosh, can we really trust the family member? And in medicine, we over and over have been proved wrong, that we just can't trust the family member. That's why so many physicians refuse to let patients drive to the hospital by themselves, right? Like they they don't trust that they're going to make it there. So we really worry about these patients. Tell me about some of the situations you've been in with diabetics like this.
So very interesting. I go back to a patient in Colorado, and it was a long haul just to get there. It was about the 17-minute, very rural. I was at one of the more rural stations in our department, and by the time we got there, um, and his blood glucose level just read low. So depending on the monitor, that could be below 25,
Mm-hmm.
could be below 50. They're calibrated a little bit differently, but he was ashen gray. He had significant diaphoresis. He had been incontinent to urine. So to me, either so obtunded and cognitively impaired that he was incontinent, or did in fact have a seizure and was incontinent. So I can't make those clinical determinations, but yet I can make best judgments in clinical hypothesis or clinical decision making based upon what we see. And how many of us are seeing these things on that level and integrating ourselves? So this person, I knew that we've been out there before, and he always said, if he was in the 30s and 40s and he was just slurring his words and just had minimal cognitive impairment compared to being completely obtunded, he said, I never want to go to the hospital. I want you to come here and give me the medicine, and I'll sign a refusal. And his family member wasn't there, and he had a son that was always there, consistently taking care of them. And this gentleman had some bread in the house, and he had some peanut butter in the house, and he had some soup in the house, and he had a lot of alcohol in the house. And not casting any aspersions, but it's kind of going to the point. This gentleman, whatever's going on, emotionally, physiologically, spiritually, physically, there's a disconnect to his overall health and condition.
Mm-hmm.
And maybe it's masking, whatever the case may be. We got there and there was nobody there. And the first thought, and it kind of goes back to your reaction, do we just get him loaded because he is so sick at this point, he's going to need to be evaluated?
Mm-hmm.
Period, point and blank. I don't know what's gone on neurologically. I don't know if there's been a stroke concomitantly with this. Even if he had started seizing, we're going to treat the seizure, even risk averse to the hypoglycemia, and stop the seizure because we know what that activity is going on in the brain. And I think a lot of times too, we're not learning that. Even just a seizure standpoint, stop the seizure. Don't worry about the
Right.
don't worry about the glucose, right? Stop the seizure. Whatever your medication is in your formulary is, stop the seizure. Glucose isn't going to cure the problem if the patient's seizing. So, but this patient, excuse me for going round and around in this loop, we got him loaded, and he had been profoundly diaphoretic. I mean, his jeans, his shirt, his sweatshirt are dripping, soaking wet, to the point where it's even difficult to get his vasculature because he was so hypotensive as well as hypoglycemic. He ended up getting an interosseous in the tibia, for which we could gain access. And at this point, we hadn't even started seeing the studies, because this is about 2005, 2006, where D10 is much better, particularly if there's an extravasation, less necrotic to the skin, less damaging to the skin if it were to get out and leak from the cells, or leak into the cell tissues. So this gentleman, he's getting D50, quick, fast, and in a hurry, because that's how we did it in 2005, 2006. And he's not budged from his basically comatose, obtunded state. So it's at this point, we can give, under the protocols at the time, another D50 or, 25 grams, right? So we did that. And again, zip, zero, not a change. And this is a person that had told us over and over and over again, I'm going to sign a refusal. And had we,
went that
any
way,
one of us, stepped up and said, if we come out here again after the second time or the first time, we're going to transport you and make an agreement. You know, honor them and yet also encourage them to be in agreement with you, because make ourselves the healthcare professionals and the educators that we're supposed to be with our patients. Put ourselves in the position to be seen in that light as an educator, as a professional, and let them know. Maybe they don't need to know all the way down to the cellular level of gluconeogenesis, all of those things, but they need to know that their physicians need to help them be in better control of their situation. And these catastrophic things will be happening. And do we need to scare patients sometimes? Politely, and I think lovingly, with grace. We need to inform them. And this patient ended up having probably about a 10-day stay, because there were so other many comorbid factors that were going on that caused him to get to this position in the situation, which any other time would have just been a hypoglycemic event, signed, sealed, delivered, refusal. Whoever was in process of acknowledging the refusal and saying, yep, just get them a signature. If there's a witness there, great. So that was one of the more difficult ones, because the patient was profoundly sick. Mm-hmm. And that does not diminish from the patient that we would get that's in his 30s and slurring and slightly combative. And we're not, we're completely making them lucid. They're getting a sandwich. I think great. And then the SEMSA article and having guidelines and stuff like that, if we can get them and sustain them in an 80 milligrams per deciliter, if they don't have chest pain, shortness of breath, other comorbid factors and symptoms, I think they're great guidelines for us to reasonably keep people at home, and then yet ask them, or even while we're there, see if they'll call their endocrinologist or their family provider if it's during the hours that they may be there. So those are a couple of the ones that we've seen. And to my chagrin, go ahead.
Isn't it funny when you have it's sort of funny, but not funny, when you have a patient who is talking to you like they're normal, and you look at them and you're thinking to yourself, gosh, you're an ICU patient right now, trying to tell me you don't need to go to the hospital. Because sometimes that's what the deal is. It's like they just don't know how bad they are, or they're in denial, or, they're hoping that D50 is going to get them through. I've had some interesting situations too. Like one time I got called to a roadside situation where the police officer wasn't sure if the patient was drunk or if they had a blood sugar problem. In this case was because this was an English as second language person. And so, it required to take a blood sugar to make sure. And we end up in all these kinds of wild situations, because then, if I have a low blood sugar patient and the police officer wants to take him to jail, now I'm in a spot to argue with the police about, what's really going on. But the other thing that I remember was that there was a time where I was riding with another paramedic, and he and I were precepting an EMT student. We took turns doing the calls, and this was his call, and it was a hypoglycemic call. And the partner I had did one of those Pulp Fiction kind of things where he was trying to revive the patient and show off, and basically told the family, after I give this medicine, you will see a complete recovery, almost like a magician or something. And it didn't work. And so how embarrassing is that for him? Now, not only did that not work, but the family's even more concerned, and you just obviously didn't assess your patient, enough to handle this correctly, because, we're looking at people that I think about those providers who are the laziest, and I think about those providers who are trying to get by with the minimal aspects of their job. And those are the kind of situations that scare me. And similar to that, in diabetic patients, they're repeat customers. So we think, I see that address come across the pager, I know that person, and it's not always the same every time.
I mean, and it's mind-numbing. We know physicians obviously are fallible, and yet they have access to so many opportunities to have measurables, liver functions, kidney functions, A1Cs, and all those things are really to see how effectively we've taken care of that patient beyond just the getting them to be cogent. When you're talking about that paramedic, the one that I hope I've never been, just wanting to pass the buck, and it's 3 in the morning and don't want to take an hour transport for a
Mm-hmm.
patient that we run 10 times in the last year. That in and of itself should be bells and whistles that there's something more going on with that person. But you say a reliable adult staying with the patient is one of the factors that we should consider, honoring a refusal. And many times over and over, we hear these news stories where the paramedic or the EMT or the emergency medical professional was not the reliable adult. The professional was not reliable. And when we say things off the cuff or because it's worked before, we can say in our best judgment, in our best clinical indications that we've seen, this has generally had a positive result in the past. We're not waving our magic wands, and medicine is as much an art as it is a science, because each patient's physiology is going to be completely different. And because it works with one does not mean it's going to work with another. And the big thing too is just because I can doesn't mean I should. And just because I haven't doesn't mean I shouldn't learn. And we get in these areas of comfortability that it's so difficult to get out of our comfort field or comfort zone when I haven't done something in so long, or there used to be psychomotor skills. Apparently the NREMT is stopping psychomotor skills within a year. I don't know how I feel about that. I've talked with some educators, full-time educators, that say there's, pros and cons. And at the same time, we've lost the interface, the empathy, the engagement from provider to patient at all levels of medicine, because now it's just seen as, in many cases, and too often the case, a transactional interaction versus a relational interaction. And our time frame to get good HPIs, histories of present illness and injury, and having a cogent, responsible witness to the event when the patient isn't or hasn't or has notoriously not been, really should be red flags for us as to whether or not we even consider refusals. We should be going in with the intentionality of transporting those patients and getting them to a different level of care. In this case, typically a physician or nurse practitioner or physician assistant, where they can really look and examine. And I think not because it's passing the buck either. And we've got to get over these arguments in medicine that, you had the opportunity and why'd you bring them to the hospital? They're at 110 milligrams per deciliter now, and they're cogent, and they're not slurring their words, and
Right.
there's no numbness or tingling or paresthesias. They're no longer diaphoretic. They don't have chest pain anymore. Yes. And this is the 10th time that we've been to their house in X amount of days. And you're just the new doctor that's on your, 20th hour of your 24-hour shift, or the 11th hour of your 12-hour shift. And we're getting just the ramifications of that, because we've brought you a patient that, by all accounts, on the eye test, the smell test, the sniff test, is okay. And that's where I think, as paramedics, as professionals, I want to strive to continue to do better. And that's incorporating the whole team concept and ingratiating the nurses and the physicians and the PAs and the nurse practitioners that we have to be in this together, despite all the fights that are intrinsically going on within our own silos.
Well, and that's a good opportunity. I didn't plan on talking about this, but the conversation I just want to push into is that, that's one of the things that's interesting about having paramedic practitioners is that if we have a PA or a nurse practitioner or a paramedic practitioner who's on the street, then there's someone that's making judgment calls without labs, right? So it's not necessarily helping their risk at all. It of course is getting more knowledge to the situation, but the fact is that we don't know everything on the bus yet. And I was a paramedic supervisor for a long time. I mean, I work on an ambulance right now, but I just have a habit of looking at everything from a management perspective. And when I was starting in EMS years ago, there were not like cameras and stuff in people's homes. And so now my worst case scenario thinking about this as a paramedic supervisor is that I have a crew who goes in to take care of a patient in the middle of the night, and they may even make them a peanut butter sandwich and, give them D50. And then what happens is they die later, and the cameras in the house prove in court that they talked them into a refusal, or that the crew didn't do their job. And so many extra things are out there to make sure that you're following those rules, and that's why I have that saying that to be a good paramedic, you have to be a rule follower. It's because of my background in management. I really believe that. I could maybe not follow the rules in some other fields, but what this article is talking about is, what are those rules? And I think that the answer is that it's saying in a lot of situations, treat and release is okay. But what you and I know from our experience is that for that to happen, there has to be provider judgment that's worth something, and then also protocols to help back that up. Because otherwise, I can see the courtroom now with that television playing the video of the crew member saying, "No, hold your pin better. Hold it like this when not even getting good situations."
Yeah, it's very interesting and confounding. And to your point, I want to again echo my feelings as a clinical manager and a field training officer and as a supervisor in law enforcement. When we don't normalize accountability conversations, when nothing is going on that is going to have an adverse consequence, and then the only time then that we have interactions with our coworkers, our subordinates, our employees is when there is a potential adverse incident or there is something that we have not done, we automatically click into that defense mode as opposed to that rational mindset where I'm here to listen. And I mean, this happens with me and my wife, let alone at work. I click into defense mode mindset because automatically I feel like I have to defend myself. And in many cases, we get more defensive when we examine guilt, when we have guilt and shame. And the guilt and shame is that we didn't follow just the simple checklist, and they didn't meet these 7 or 8 criteria that are easily a checklist. And everybody reverts back to, and when you flew, you understood checklist and safety and why airlines are so safe, because we have checklists.
Yep.
It does not, the risk aversion is not decreasing the education and the mindset that we have a checklist because we're less prepared and less educated. It is so we protect ourselves when our cognitive abilities, because we haven't eaten or we haven't slept or we have stressors and our cortisol levels are flying around and our epinephrine is flying around and we're not making the best decisions. These checklists will save us and our patients hardships and trauma and potentially significant monetary loss as well.
Yeah, and I'm thinking about the new paramedic that hasn't had a lot of these patients. And one of the benefits of my time working in the ER and the ICU is that I have seen patients that eat, take their insulin, and just drop. Some of the word that we use is brittle. Some of these diabetics are really brittle. And so knowing that helps the provider also make a judgment call. And while we're talking about that, it's the same thing when we have overdose patients. If you've had experiences where you've given Narcan and they pass right back out and quit breathing again within 5 minutes of you giving it, it's a testament to the fact that patients have to be monitored, because we don't have just quick fixes like we wish we had. Like Narcan and D50 don't do everything.
100% agree. And when I got into the fire service in EMS, and the fire department in Colorado sent me to paramedic school. And that was when there was this big push for paramedicine. And we had this kind of urban or suburban, rural kind of interface. And, there is a need, I believe, truly for paramedics and paramedicine in the place of a physician, which I think if we go back to that mindset, we have victims and we bring to the hospital a patient. The mindset of in the place of a physician. And we have devolved to the level of, here's a program, you pass the test. Here's the program, you pass the test. And our education system, unfortunately, and I don't want to digress too significantly off the topic, but we have a significant issue when we're not following evidence-based medicine, when we're not even sharing with our subordinates, our employees, our clinical teams, these articles, that just, if we just had, nobody's saying you can't use it. It's not theft if you're taking the same 7 or 8 things here And if the checklist fits, you don't transport. If any of them don't meet the measurable, you transport, or you at least do your darndest to get the patient to go with you in case there's an adverse incident.
Mm-hmm.
So with that being said, the opportunities for us to be better practitioners and providers, and paramedics do treat and we do diagnose. And this whole argument that still goes on, if you watch or follow any of the social media platforms, where people still will to this day say we make a clinical judgment and then treat based upon that. I can accept that that's their feelings, and I obviously also don't have to agree with that. I am going to ingratiate the creativity and the continuation, the collaboration, the conversation. And by continuing to share things like this, in this article about hypoglycemia has taken us to the areas that really, if we were to shine our light into, play a bigger role than us just not even following potentially a simple checklist, an appropriate checklist to determine whether we do a refusal or not on a patient. And we are so woefully disengaged. We're fighting for money. We're fighting the IFF against the so-and-so, and the third service versus the private, and the not-for-profit versus the hospital-based. Essential doesn't mean essential in every state, and municipality is the same. And so everybody's worried about money, and everybody's worried about position, and everybody's worried about all these things. And if we took care of ourselves and we took care of those that we're enlisted to be professional for, I think we could do a paradigm shift just in that. And the other thing, and we talked about research, who does the research for paramedicine? Nurses and physicians. And without physician oversight, we could never have a job. So I'm not discrediting and dismissing that, but it's every other profession is doing research for paramedics, short of several, if you look at Europe, excuse me, and Australia in particular. I think it's Manhasset.
Monash University.
Yeah, where they're doing doctorates in paramedicine, doctorate levels, master's levels, paramedic level practitioners. And you hear people in different positions across EMS that have said, we want to have you be paramedic practitioners, and we want to do this, and we want to increase the education. Well, the big two or the big three told us a few weeks ago that they don't want that because there's a shortage in paramedics.
Yeah, and I understand both sides, but
yeah,
one of the purposes of this show and what I'm up to is I'm trying to fill some of that gap here in the United States. I know that the reason that I got my PhD in human development is because I couldn't get a PhD in paramedicine. So I was lucky enough to find a school that would let me write and research whatever I wanted to, which is all paramedic stuff. But those opportunities aren't so big out there. And so when we talk about the research arm, it's different than the clinical arm. But yeah, I think it's awesome how we are making some progress.
When I started looking over the material and started doing a deeper dive into some of the other research, it reminded me of why I love paramedicine and the opportunities that we have to take care of a human for them in potentially the worst circumstance of their life. And at the very least, to show people that we do have an education and a training and a mindset to deliver and make good on our promise to do the best for another human being, regardless of race, creed, gender orientation, and et cetera. And I think this opportunity continues to embolden me to be stronger, to speak out when one of us is not doing that, to hold one another accountable without casting aspersions, to lift us up as opposed to tear us down. And the opportunities that I've listened to you today and other opportunities that I've had to hear you, it's about driving knowledge, driving skill, and driving collaboration so that we can empower ourselves and better the profession. And to have the opportunity to be here has been fantastic. So I just want to say thank you, and hopefully I didn't disappoint
Oh my gosh. So
for the conversation.
the last paragraph of whatever you just said sounded so professional and polished and wonderful. And but thank you for that. And that's what we're up to doing here. And so thinking about the human factors and thinking about the best way to make our field better is it's all about this. So thank you for being here.
Well, it was wonderful. I appreciate you very much.
I also want to invite you to check out my latest book. I co-authored the book with Four Arrows, who is 2 doctorates and is also an expert on indigenous scholarship and hypnosis. So I just want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of those properties found in hypnosis. This book works to change the way we approach and interact with the emergency patient, especially the emergency patient that's in acute kind of distress. And my goal with the book is to help make you be a better practitioner. So the book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can follow the link below to find it or go almost anywhere where you can find books online to buy. If you want me to autograph your book, I'd be more than happy to. It's just easier for me to mail you an autograph sticker than it is for you to mail me your book because I already got a couple of those in the mail from friends. So don't mail me your book. Just let me know and I'll send you an autograph sticker that you can put inside your book. So I hope you get a chance to check it out. The other thing to share is I'm doing a research project related to first responders who live in the United States. And I could use your help if you don't mind being interviewed over a video call. It takes about an hour. So go to my website and fill out a form, professorbram.com. So it's professorbram.com.
Hi, I'm Will Chaplot from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for your review on our website at iphmi.com and also published through GEMS Online magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field or what we should be doing in the field or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials. Relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
Thank you again for listening, and I look forward to sharing more insights with you in this next episode. So if you enjoy the EMS research, please tell your friends and like, share, and subscribe to help others get the message, and hang on for the credits at the end. Thanks.